Hello, I'm very pleased to be joining you today from Victoria, British Columbia, Canada. It is a lovely spring day here, but I'm still very sorry that I can't be there in person with you in Sydney. In this presentation, I'm going to be speaking about issues of access and equity in substance use service systems. But before I get started, I would like to acknowledge that I work and live on the traditional ancestral territories of the Lekwungen peoples, specifically the Songhees, Esquimalt, and WSÁNEĆ, whose historical relationships with this land continue. I am an uninvited settler on these lands, and I've been here for about the past 5 years. If you've ever been to Vancouver Island, you will know how beautiful it is here in this part of Canada on the Pacific Ocean, and I'm very grateful to be able to live here. When we're talking about substance use service systems, high quality care is typically defined in terms of being effective, efficient, responsive to people's needs, accessible, safe, and equitable. In this presentation, I will be focusing primarily on access and equity, including what I've learned from my research about the ways in which equity is defined, monitored, and enhanced within treatment systems, and how that all plays out for people when they're accessing services and supports for substance use. When I talk about services and supports, I'm doing so in a very broad sense, so inclusive of a range of pharmacological and psychosocial interventions, counseling, offered on a residential and outpatient basis, whether therapeutic or preventive, and with the goals of abstinence as well as the reduction of harms. With that in mind, I'll propose that it's a core principle of effective substance use service systems that they attend to diversity and social structural disadvantages. This comes from a systematic review that I did a few years ago with Dr. Brian Rush, also a substance use services researcher in Canada. We did this study to identify high-level goals of substance use treatment systems so that we'd be able to have an evidence-based organizing framework that would help us in our work, as well as others who do system-level evaluations. So the idea being that researchers and policymakers would be able to apply these high-level goals or principles to help them decide where to focus their efforts when they're doing an evaluation, or where to focus their efforts when they're trying to enhance their local systems. But what does it really mean to attend to diversity and social structural disadvantage? And how might we go about enhancing it? This framework is a work in progress that our team is developing to guide a larger program of research at our institute. With Dr. Bernie Pauly, I co-lead an initiative called the Collaborative Community Laboratory on Substance Use and Harm Reduction, which we call CoLab for short. It's a collaborative network for research and knowledge exchange that includes monitoring and surveillance activities, as well as services research and a community of practice for people who use drugs, service providers, family members, policymakers, and other researchers. And our draft framework is based on work that was done by the World Health Organization's Commission for the Social Determinants of Health. As I said, it's under development, but I show it here because it helps to illustrate where diversity and social structural disadvantage fits in and how they relate to service systems in influencing health outcomes. So social structural disadvantages are the root causes of health and health inequities. They're based in socio-political context and structures, such as governance, cultural and social values, and policies. They vary by geography, and they lead to the social stratification of a population according to their socio-demographic characteristics. This, in turn, influences individual level factors such as biology, psychosocial and material circumstances, and health behaviors, including substance use. Systems, services, and other responses, which do include AOD services, as well as other health, social, and legal services, are reciprocally influenced by the socio-political context, socio-demographic composition of the population, and those individual level behaviors and circumstances. Accordingly, systems and services have differential impacts on substance use harms, health, and wellness. I've increasingly been trying to situate my program of research on substance use services within this bigger picture that recognizes how population patterns of help seeking and people's experiences of services are fundamentally shaped by these social structures. I do this by pairing population-based studies that draw from monitoring and surveillance activities, as well as health administrative data, which is where primarily my training lies, with smaller targeted studies that use qualitative approaches to probe really how those inequities are shaped and how they play out for people. I will now turn to some findings from my prior research that have shaped my thinking on this subject. To really get a sense of who is able to access care and who is experiencing barriers, you have to look outside the service system and assess population level need and how this relates to help seeking. In the Canadian population, and the same is true in Australia and other developed nations, the majority of people who experience problems related to their substance use don't seek services. This happens for a variety of reasons. In this study, we looked at service use and unmet needs. And we found that 65% of people who met the criteria for a substance use disorder in this national representative survey did not seek any services or supports. Among those who did, the most common sources of support were informal, through social networks, self-help groups, and internet chat groups. Now, this study predated COVID, and it would be really interesting to take another look at this since internet-based interventions have really grown over the past year. But back to issues of inequity in service receipt. Identifying as a man, being older, or being a member of a racialized population, having lower education, all reduce the odds that you would have received services. And this is controlling for need, both perceived need as well as diagnosis. Now, not everybody who experiences problems related to their substance use perceives a need for care. We know that. So we also just restricted the sample to those who did perceive a need. Among those who met the criteria for a mental disorder or a substance use disorder in this survey, and who perceived a need for care, having a substance use disorder alone predicted having unmet needs. And this association persisted after we controlled for whether or not someone had received care. So that's quite the finding. Unfortunately, these findings largely replicate those from a study that we did a decade before. People with substance use problems are by and large not having their needs met by the existing healthcare system. Now, it's difficult within the confines of a general population survey to get a good sense of the factors that underlie these patterns. But this is really where we see the influences of socio-political context and structures, particularly the impacts of drug policies, cultural and social values. Substance-related stigma plays a major role in help seeking. The quote on this slide is from a study of perceptions of safety in healthcare services among people who use alcohol and other drugs. And in this study, stigma emerged as a key element that prevents people from seeking the healthcare that they need. The stigma associated with substance use is deeply embedded in health and social systems as a result of current policies that criminalize drug use and neoliberal beliefs that people who use substances are solely to blame for their problems. Illicit drug use in particular is highly stigmatized, especially when it's coupled with other structural disadvantages such as homelessness, colonialism, racism, classism, sex and gender discrimination, and poverty. Socioeconomic disadvantages and associated processes of social exclusion contribute to inadequate access to healthcare, including but not limited to services for AOD. Feelings of not being safe in healthcare settings due to fear of judgments and stereotyping can lead people to delay and avoid seeking the healthcare that they need. Help seeking for substance use is interesting and somewhat unique. Theories of help seeking developed in other areas of health, wherein people recognize a need and then seek out services to alleviate symptoms. These models don't apply in a straightforward way to a sizable proportion of people who are in AOD treatment. Help seeking for substance use is typically preceded by an event that either alerts the person themselves to the need for care or alerts an institution, such as the legal authorities, child welfare, healthcare provider, or family and friends, who may then encourage or compel treatment. Pathways to care are accordingly negotiated processes that can be rooted in people's social positions and their abilities to successfully advocate for their own decision-making as a result. Studies of treatment mandates can help us to better understand these pathways to care and how they affect access and equity. By mandates, I'm referring to what's known as quasi-compulsory treatment, in which people are given a choice between treatment and a sanction of some sort. There is increasing attention internationally to mechanisms of actual compulsory treatment, such as through civil commitment. However, these mechanisms are still fairly rare in North America, and particularly in Canada. In this unpublished study, we looked at the composition of the treatment population based on whether or not they were mandated within a large public system of specialized AOD treatment in Ontario, Canada. And that's a province of Canada. It's approximately 14 million people. And what we found was that 20% of people who enter treatment in a given year in Ontario are mandated by either the legal system, child protection, or their employers. I will say that although 20% of people overall were mandated, this prevalence varied systematically across subgroups. And for one, we've found that in this same treatment system, 50% of women who were either pregnant or parenting a child under the age of 7 when they were admitted to treatment were mandated by child protection services alone. Being young, having a fixed address, so having secure housing, having a job, and low education all predicted being mandated. However, the odds of a mandate appeared to actually be lower in subgroups characterized by multiple social disadvantages, such as homelessness in combination with low education and employment. We saw this pattern of findings by looking at the interactions between socio-demographic characteristics and how they associated with whether or not the client was mandated. This general finding actually appeared to hold for both men and women. So to the extent that social disadvantage is both a cause and consequence of escalating substance use problems, these findings are consistent with other research that has shown that people who are mandated to treatment generally exhibit lower problem severity than do non-mandated clients. And this raises questions about who tends to be captured by our current mechanisms for mandating people to treatment. Now, once someone accesses services, there are equity considerations in their experiences, whether they engage and whether they decide to stay. So these findings come from further analyses of Ontario's system of AOD treatment. In this particular study, we looked at 2 common performance measures of retention in outpatient treatment, called treatment initiation and treatment engagement. They are based on the timing of visits that occur in the initial weeks, so that early period of a treatment episode when we know the dropout is particularly high and people are actively engaging in a decision making process around whether there's good fit for them and whether they're going to continue. We found that 50% of people who started treatment received a second visit within 14 days. That's the definition of treatment initiation. And only 30% met the criteria for treatment engagement, which is having another 2 visits within 30 days of initiation. Basically, having 4 visits within the first month of being admitted. Interestingly, identifying as a man, being younger, having less education, and being mandated all reduced the odds of both initiation and engagement. Overall, the magnitude of associations with client characteristics were fairly small, so the odds ratios tended to be around 2 or less, suggesting that initiation and engagement, these measures of retention, were not overly localized to specific population subgroups. At a system level, however, it is really clear that there are difficulties retaining clients who enter outpatient treatment, and that most of these treatment episodes are of limited duration. The finding that mandates reduce the odds of initiation and engagement is pretty interesting because this is typically not the case in much of the literature that has come out of the US. In general, this literature suggests that being mandated is associated with a longer time in treatment. I suspect that this difference that I have found in my research, and I found it repeatedly in a number of different studies, reflects differences in socio-political context, specifically differences in how drug-related offenses are dealt with in the criminal justice systems in Canada versus the US, and differences in the policies and practices that govern mandates. So for instance, what is being mandated? How long do people have to go to services? Of what kinds? So far, I've summarized some of the work that I've done investigating access and equity in substance use service systems. To end off, I want to bring things back to where we started, to the core principles of substance use service design. Yes, an equitable system will attend to diversity and social structural disadvantages in the population. But a substance use service system is complex and it's adaptive. There is no single intervention approach that works for everyone who runs into problems with their substance use. And this means that an effective system is going to ideally be able to offer a plurality of options for this population. Further, systems can be entirely legitimately instantiated in different ways, depending on local and regional needs, strengths, and histories, such that they may look quite different when you look at them on the ground, and that's okay. So I will add to the core principles of system design here. An equitable system will also be one that is designed to address the full spectrum of needs and issues related to substance use, including substance use itself, problems related to substance use, and substance use disorders. A third core principle of substance use treatment effectiveness is that the accessibility and effectiveness of services for people who have problems is going to be improved to the extent that stakeholders collaborate. For women, this means collaboration with child welfare and collaboration with prenatal care, primary care. For the system as a whole, there needs to be integrated services that attend to the social and structural determinants of health, such as housing and income assistance, over and above a focus on substance use itself. And finally, an equitable system of care will be one that offers systematic screening, assessment, and individualized treatment planning. so that we're able to detect and support access to the system and match people to the evidence-based interventions that they need across a full continuum of care. So where are we now? Well, in Canada, as in many countries around the world right now, we're dealing with the dual public health emergencies of overdose and the pandemic. In the province where I live specifically, in British Columbia, last week we hit 5 years since a public health emergency was declared for overdoses. The illicit drug supply is toxic and it's contaminated with strong synthetic opioids and increasingly also benzodiazepines. Since 2016, 20,000 people in Canada have died of overdoses, with several times more impacted by non-fatal overdoses with related brain injuries, trauma, and other life-altering consequences. The overdose emergency is now coupled with the pandemic. We are in the dubious position in British Columbia of having our Public Health Act used simultaneously for 2 health emergencies, which is truly a rare event. And we are seeing these emergencies interact. The disruption to the illicit drug supply routes because of COVID means that drug content is more unpredictable. And the services that have been set up in the initial years of the overdose emergency have been disrupted. We experienced record levels of overdoses in 2020, and the rates continue to be high in 2021. And there is no equity in how this solution has played out, with high rates of overdoses and other unintended consequences of COVID public health measures being felt disproportionately by those who experience structural disadvantages. To name a few, this includes Indigenous communities, other racialized groups, people who are unhoused, and women who are involved with the child protection system. As our coroner noted early on after the pandemic was called, the one thing we know from our data is the people who are dying, many of them are dying alone. And so the complications with the dual health emergency, with the COVID-19 pandemic and the illicit drug crisis, we know that people have been isolated, and we know there's been unintended consequences for people who use drugs during COVID. If we needed a signal that our systems are inequitable, the pandemic has made that clear in Canada. Thank you for listening. And here are some links to my work and to the research center where I am located. Thank you.